Right, visible?
Visible, sir.
Okay. So the few points, it's an interfacial plane block. Nowadays, you call it as facial and interfacial plane block as the terminology that is used. It is performed in the thigh, and it is usually producing analgesia for surgery of the knee, medial lower leg, and ankle, as we rightly mentioned. Has been introduced as a pure sensory nerve block for postoperative analgesia following any knee surgery, like what you mentioned as ACL repair or turkey knee replacement. Because it's a purely sensory, mobilization and ambulation of the patient is much more easier. So saphenous nerve is part of the operator nerve travel through this adductor canal, and they can be blocked by injecting local anesthetic in the canal, which will provide adequate analgesia. And it preserves the quadriceps strength, so it helps in ambulation. And general considerations common to all peripheral nerve blocks. Whenever you do a block, you have to write in your exam that what are all the precautions you will take. That you must keep all the emergency drugs ready, must inform the patient and get them a consent, and all monitors should be in place. All these things should be routinely written for any block question that is asked in the theory. So otherwise, at least you have to make mention like this: general consideration common to all peripheral nerve blocks, including patient preparation, counseling, monitoring, use of aseptic technique, localization technique, drug choices, contraindications, complications, everything should be taken care of. And coming to the anatomy, sartorius muscle descends in the lateral to medial direction, it goes across the thigh and across the anterior thigh, forming the roof. And the sides of it's more or less a triangular canal formed by the vastus medialis laterally and the adductor longus magnus medially. Femoral vein accompanies the artery and saphenous nerve are located within the canal. Okay. So, so this picture will give you an idea about this is the sartorius muscle. So this forms the roof. So this is vastus medialis and this is adductor magnus. So these three things can make a triangular shape like this. Femoral artery is there, femoral vein is there, and saphenous nerve is here. Okay. So these are all the structures, and this is the ultrasonographic view. So they have made the adductor sartorius muscle, adductor magnus, vastus medialis, and the saphenous nerve is seen as a small white dot here. Okay. So even if you are not able to locate it properly, just go close to the femoral artery without puncturing it and deposit as close to the vastus medialis side. You will be successful. So you don't have to search for that. So even if you are not able, because very difficult to find out the small white dot among all these major white reflections that you are seeing. So go close to the femoral artery, make sure that it is in the border, and in the small gap between the muscle and artery, if you deposit, you will be successful. So that's how you can manage the block. So it's typically performed in patients in supine position, thigh abducted and externally rotated to allow access to the medial thigh. So I always prefer to write the answer as 4 P's: preparation of the patient, position of the patient, palpation or identification of the structure, and puncture. So from which direction you go, what depth you have to go. So if you remember these 4 points: preparation, uh, position, preparation, palpation, and puncture. So nowadays, instead of palpation, that palpation is identification technique using ultrasound or peripheral nerve stimulator. So that can be easily written, and that will have a nice presentation also. So I think we are done for the day. Doubts or any questions?
Thank you, sir.